Okay, learning objective. By the end of this lecture, you should be able to list signs and symptoms of bacterial meningitis, to be able to explain the complication and how bacterial meningitis is diagnosed, be able to design the monitoring therapy used in bacterial meningitis, and should be able to solve patient case-based problem. So meningitis is an inflammation of the meninges due to infections by bacteria or fungi or virus. Etiology. The causative organisms are related to the age of the patient and the presence of underlying disease. For instance, the bacteria causing meningitis in neonates may differ from those that may cause meningitis in adults. Neonates, you will see group B streptococci are the most common. Then, of course, you will see others that are less common, like Listeria monocytogenes, Staph aureus, E. coli, Enterobacteriosity, and Enterococci. In adult, you will see Haemophilus influenzae, type B, Neisseria meningitis, and strep pneumoniae. So those are the causative organisms, and it's important as a pharmacy personnel to be aware of the causative organism. Okay. I have a question for you. In adult, which causative organism is notifiable? In adults, which causative organism is notifiable? Do you understand that question? Anyone?
Yes, sir. Hello.
Yes, Derek, you can go ahead.
Yeah. I think there are two. Most of them. The first one is Streptococcus pneumoniae. That's the most one, and then Neisseria meningitis. I think that's what I'm thinking. The first two.
Are notifiable?
Yes.
Okay. Any other contributions, subtraction, addition? Yes. Any addition or subtraction? From the contribution Derek has given, okay, only Neisseria meningitis is notifiable. He said if there is an outbreak, it's then a public health issue. Okay. And
sorry, sir. What do you mean by notifiable in this case?
I didn't even ask. Who knows what means notifiable? Anyone who knows? Absolutely. Okay. Because Neisseria meningitis is very common in the camps, in the boarding houses. Okay. So it should be reported. When you hear notifiable disease, it means it should be reported. Okay. Clinical features of meningitis. Patient usually presents with headache, neck stiffness, photophobia, fever, and vomiting. Okay, those are clinical features. Nausea, photophobia, neck stiffness, and of course, headache and fever. Also, if the kinin test is done, in most cases, it is positive. Okay. Kinin test is when the leg for the patient is resistant to extension. When the hip is flexed. Okay, and this is due to irritation in the lumbar area. Also, in some form of meningitis, we experience hemolytic skin reaction. Okay. Also, how do I know? Somebody can we all mute? That one, someone to mute. Yeah, so fever, headache, altered mental status are usually due to encephalitis. Okay. Sometimes meningitis may be accompanied with seizures because of focal neurological deficit. Okay. So, how do you test that somebody is confused if they're in hospital? What question do you ask? Those who are internal medicine or anyone who knows? For mental status, how do you assess if the patient is confused because of meningitis? Anyone? It's a very simple test that you do. You ask the patient where they are. Where are you? Somebody will answer, I'm in Mufulira, but yet they're in UTH. Okay, then you know, or what's the time? It's in the morning, they will answer, no, this is evening. Then you know that they are confused. Okay, that's how you assess the mental status. Complication of untreated meningitis, seizures, focal cerebral signs, cranial nerve palsies, okay, lack of sensitivity, loss of consciousness, of course, death. Those are the complications of meningitis. Diagnosis of meningitis, bacterial meningitis. So a lumbar puncture has to be performed, very safe. There's usually a myth regarding lumbar puncture. So from today, after this lecture, please encourage your community where you live, your relatives, friends, that lumbar puncture is safe and saves lives. So from lumbar puncture, all you're interested in is to get the cerebrospinal fluid to detect if it's bacterial, if fungi, or viral. So you usually do biochemistry. So the normal cerebrospinal fluid is colorless and it has cells up to 5 microliter. Those are polymorphs. Then protein concentration is up to 0.4 grams. Glucose is 60% of blood glucose. Okay, so usually it's between 2.2 to 4.4 of the body, of blood glucose in the body. Okay. So I repeat, the diagnosis is you have to do lumbar puncture, you get the fluid, you do biochemistry, then you assess. Okay. The normal colorless, the normal cerebrospinal fluid is colorless. So if it's turbid, then there's a problem. If the cells are more than 5, there's a problem. Protein more than 0.4 grams. So it depends on the type of causative agent. Is it fungi? Is it viral? Or is it bacteria? Are you able to see that? Hello? Are you able to see?
Yes.
Good. Okay. So this table summarizes the abnormal cerebrospinal fluid in relation to chemistry. If it's bacteria, if it's viral, or if it's fungi, what are you going to see? Starting from the pressure, the color, proteins, glucose. Okay. So let's start. Pressure. The normal for cerebrospinal fluid pressure is 5 to 20. In bacterial, it's usually greater than 30. Okay. Viral may be normal or mildly increased. In fungi, no effect. Appearance. Okay, we have said colorless. Okay. In bacterial, it's turbid. In viral, the fluid will be clear. In fungi or TB, you see fibrin web. Okay. Fibrin web will be seen. Then protein, normal 0.1 to 0.45. In bacteria, it's greater than 1. Viral, less than 1. Okay. In fungi, between 0.1 and 0.5. That is fungi or TB. Glucose, normal 2.5 to 3.5 or to 4. In bacteria, is less than 2.2. That is less than 50%. In viral, to be normal, fungal or TB, 1.6 to 2.5. Gram stain. In bacterial, there is 90% positive. Viral, normal, fungi, nothing there. Glucose serum ratio, 0.6, that's normal. In bacterial, less than 0.4. In viral, greater than 0.6. In fungi or bacteria, fungi or TB, less than 0.4. White blood cells count. Normal is less than 3 cells. In bacteria, you will see greater than 500 polymorphs. In viral, less than 1,000. In fungi or TB, is between 100 to 500. Okay, then there are those others. So that's right now summarizes for bacteria. I just picked now from that table to give you for bacteria. So the cell count is 500 to 2,000, and usually lymphocytes are predominant cells. Proteins between 1 to 3 grams. Glucose is less than 50% blood of that of the blood glucose, or just say below 2.2. The one I gave you here. Okay. So that's how you do diagnose bacterial meningitis. Let me repeat. If it's bacterial meningitis, the lymphocytes, which are predominantly polymorphs, will be between 500 to 2,000 microliter cells. Then protein will be between 1 to 3. So proteins in bacterial infections are elevated in the cerebrospinal fluid. In 10 minutes, we need to rejoin. Then glucose will be less than 50%. That's all. That's the take home. I repeat, take home. In bacterial meningitis, the cells are between 500 to 2,000. Then proteins are elevated. Glucose is low. So proteins high, glucose low. Cells high. As simple as that. Monitoring. Patients require close observation and monitoring of vital signs during treatment to ensure response to therapy. So you need to do serum C reactive protein Also, you need to do white cells counts. Okay. The normal CRP levels are below 3 milligrams per liter. Okay. Then you repeat examination of CSF from time to time. You do the biochemistry. So if you start treatment and the patient is responding, the cells should be back to normal, less than to 5. Proteins should be up to 0.4 grams, should be less. Glucose should be able to increase and be normal. So that's how you monitor therapy. Okay. Treatment, you consider pharmacokinetics of drugs. So antimicrobial therapy requires attainment of adequate levels of bacterial antimicrobial within the cerebrospinal fluid. We all know that any drug that's supposed to be used in meningitis should be able to cross the blood-brain barrier. Okay? So the passage of antibiotics into the cerebrospinal fluid is very important, and it depends on the following: the degree of meningeal inflammation, the integrity of the blood-brain barrier, and the pharmacokinetics properties of the antibiotics. Okay. We know that some antibiotics will penetrate the BBB, blood-brain barrier, when only the meninges are inflamed. Some, they'll penetrate whether the meninges are inflamed or not. So you need to consider all those factors when it comes to treatment. So what are the pharmacokinetics properties of an ideal antibiotics? The one which is supposed to be used in patients who has meningitis. Should be highly lipophilic. Should be able to dissociate at blood pH. Now that is the controversy at times, because we all know that the drug that is dissociated has low lipid solubility, hence poor absorption. There should be low protein binding. We know that the only drug that is available for distribution is the free drug, not the drug that is bound to protein plasma. Which protein plasma do you know that bound a lot of drugs? Miriam? The question is, which plasma protein that you know that binds a lot of drugs, or that is present in the plasma? Miriam?
I've forgotten, sir.
You have forgotten?
Yes.
Okay. Cavo?
Albumin, sir.
Yes, albumin. Good, albumin. So albumin is a major protein that is found in the plasma, and it binds a lot of drugs. Also, the molecular weight of the drug should be small for easy penetration. And the concentration of the drug in the serum should be pretty high as well. Okay. So careful selection of antibacterial for management of meningitis is very, very important. Okay. To avoid drug resistance. Classification of antimicrobial according to their ability to penetrate the cerebrospinal fluid. We have those antibiotics that can only penetrate the meninges when they are inflamed. Yeah. First, let me start with those that can which penetrate the meninges even when they are not inflamed, like chloramphenicol, metronidazole, isoniazid, and pyrazinamide. We have also antibiotics that penetrates only when the meninges are inflamed and should be used in higher doses, like rifampicin, quinolones, and beta-lactam antibiotics. Then we have those that penetrate poorly at all circumstances. Aminoglycoside, erythromycin, and vancomycin. Carbo, can you mute? Carbo, can you mute? So that's how you can classify antibiotics according to the ability to penetrate the cerebrospinal fluid. What are the goals of therapy for management of bacterial meningitis? You need quickly to control the infection, and the patient should be quickly stabilized so that you reduce the morbidity and the mortality. Recommended regime, usually third generation cephalosporins such as cefotaxime or ceftazidime, alongside with amoxicillin or ampicillin are used empirically. Okay. For neonates meningitis, cephalosporins penetrate into the cells better than aminoglycoside, so they are good choice. Okay. Cefotaxime and ceftazidime are all third generation cephalosporins. I have a question for you. What's so special about ceftazidime as the third generation cephalosporin? Then amoxicillin or ampicillin plus cefotaxime or ceftriaxone is the recommended treatment in infants between 1 to 3 months. Therapy with amoxicillin and ampicillin and gentamicin is unsuitable in this age group. In older infants, children, and adults, third generation cephalosporins such as ceftriaxone are recommended. So let me take you back again. For treatment of meningitis in neonates, we can use a third generation cephalosporin such as cefotaxime or ceftriaxone alongside with amoxicillin or ampicillin. Okay. What does ampicillin cover, especially in neonates? Anyone who knows? Those in pediatrics, ampicillin, if ampicillin is covered, is prescribed or added to a third generation cephalosporins, What do you think is being covered in terms of spectrum of activity? Anyone? Who are pediatricians here?
Nicholas is a pediatrician.
Yes, tell us. Okay, they will tell us as we go. Then for infants between 1 to 3 months, you can use amoxicillin or ampicillin plus cefotaxime or cefotraxone. Okay. Then for older infants and adults, cephalosporins, as well as this, such as cefotaxime or is recommended, cefotaxime. Okay. So in summary, that's the table for the choice of antibiotics and alternative therapy. Okay. So we have the first choice and second choice. Giving the summary of what we have discussed. Now, it's important to note that at times penicillins might be prescribed in milligrams. So it's very important that you acquaint yourselves with the units of penicillins. For instance, benzylpenicillin potassium, 600 milligram, or benzylpenicillin sodium, 600 milligram, is generally been considered to be equivalent to 1 million unit rather, or 1 mega unit. So 600 milligram is equivalent to 1 million units or 1 mega units. And mostly, each vial of benzylpenicillin is 5 mega international units. It means it contains 3 grams of benzylpenicillin sodium. Okay. So you should be acquaint yourself with those calculations in case a prescription comes in milligrams, you should be able to convert easily. Duration of treatment for treating meningitis. Usually, the maximum benefit should be 10 days for any empirical therapy. Okay. But if the causative organism is known and it is Neisseria meningitis, 7 days. If it's Staphylococcus pneumoniae, 14 days. Hib type B, Hib, that is Haemophilus influenza type B, 10 days. If it's Listeria monocytogen, especially in children, you go up to 21 days. Now, anyone to give me the answer regarding the coverage of ampicillin? What microorganism does it mostly cover in children? Okay, we still wait. That slide is simply showing the antibiotics and the cerebrospinal fluid to serum ratio, the peak concentration, and minimum effective concentration for certain microorganism. I request that you don't start memorizing those things, just information for you. If you don't know, it's fine. You won't be crucified. Prophylaxis against the meningococcal infection. So if your relative, your friend, your neighbor comes into contact with a patient who has meningitis, and the diagnosis has been made that it is meningococcal caused by Neisseria meningitis, and they came into contact with the patient, quickly you need to be on prophylaxis. Preferably within 24 hours. This is to eliminate the nasopharyngeal carriage. If you are in contact with a patient who has a meningococcal, you might be a carrier. So quickly, you should be put on prophylaxis prevention. And those are the following drugs that are used for prevention: Cipro, 500 milligram per oral. Just a single dose, 500 milligram is enough. Rifampicin, 600 milligram twice a day per oral on 2 consecutive days. For women who are pregnant, because they may not use Cipro, we can use azithromycin, 500 milligram as a single dose. You can also use cefotraxone injection, 250 milligram intramuscular route as a single dose. The take home is anyone who has come into contact with a patient with meningococcal, who has meningococcal infection, has to be on prophylaxis. The use of steroids in the bacterial meningitis. This is very important, regardless of the etiology. Steroids have been shown to improve quality of life, reduce mortality and morbidity in patients who are patients with meningitis. So usually you start a steroid, dexamethasone, 10 to 20 minutes before the antibiotics. Or you start exactly the first dose as you are starting, you also start the steroid. Then on day 4, you can stop. Then you continue with the antibiotics. It's only for 10 days only. For adults, 10 milligram 4 times a day for 4 days. Children, 0.15 milligram per kg. Okay. Corticosteroids, as we know, reduce the inflammation and restore blood-brain barrier. And some people, no wonder you just use it for a short period of time. Because if you use it for a long time, you know the issue of lowering the immunity, side effects of corticosteroids, and also restoring blood-brain barrier. Antibiotics have problems to pass through, especially those that depends on the meninges being inflamed for their passage, like beta-lactam antibiotics, the cephalosporins, the penicillins. What are the benefits? One of the complications for meningitis, as we discussed, is neurological disorders. You may end up having severe hearing loss, or paralysis or speech loss. So no wonder it's very important that steroids are started 10 to 20 minutes before or exactly the first dose is introduced. You also start for 4 days, regardless of etiology. Any questions for me? You've been so quiet. No wonder I like the physical lectures. Any questions from what we have covered so far? Mupeta, do you have questions for me?
Oh, sorry, sir, I just wanted you to clarify on the modes of transmission of bacterial meningitis itself. Yes, sir.
The mode of transmission?
Yes, sir.
Yeah, they differ. Like if you see Neisseria meningitis, just through the droplets you might get it. Okay?
Yes, sir.
Yes. Then if you are immunocompromised, because the same bacteria, they may cause UTI, like E. coli, right? So if you are immunocompromised, you find yourself that this bacteria travels to the brain and you have meningitis. Okay. Yeah, so, or through the catheter, cannula, there are a lot of ways in which you can get meningitis. But in immunocompetent patients, meningitis is very, very rare. Okay. Currently, mostly those that have meningitis are immunocompromised patients whose immunity is weak. So if your immunity is weak, you have diabetes or you have HIV, you need to have ways in which you can prevent infections. To put in measures, infection prevention measures to be put in place. Okay. Avoid unnecessary visits into the wards. Some infections are community acquired, some are hospital acquired. Any other questions?
Hello, sir.
Yes, sir.
Yes. Very.
How is encephalitis?
I'm not getting you.
How is meningitis able to cause encephalitis?
Okay, first, do you understand encephalitis?
Yes, sir, I do.
What is it?
It's the inflammation of brain tissue.
Yes. And the meningitis is simply inflammation of the meningeal membrane. So because of the bacterium has attacked the meningeal, then the inflamed, also the brain tissue becomes inflamed. Because the meninges is part of the brain. Okay. Chichi. Any questions from Chichi? Dorika, Chola, Mbao, Cynthia, Derek?
No, sir,
Diana?
everything is clear.
Everything is clear?
No, sir, I have a question.
Sure.
Yes, I want to understand on how does just coming to cross contact a patient and then you also you can have the same disease like in meningococcal infection. So like how does it happen? Maybe the mode of transmission, how does it occur? Just coming to contact with the patient, because the way I'm viewing it, since maybe the bacteria is in the meninges there is destroying now, how can just touching the patient and then you acquire the same bacteria? That's where I wanted to understand there.
Okay, let's go back to prophylaxis. You understand from there when we were saying prophylaxis. Let me see. There. The second bulletin says chemoprophylaxis is given to eliminate nasopharyngeal carriage. So, Shimba Dorica, can you mute? Dorica, mute your mic. Good. Yeah, so, Derek, so the Neisseria meningitis harbors in the nostril area, the respiratory system. So, through the droplets from the nose, you can get it. No wonder if in boarding, like those in Ridgeway or Med campus, if 3 or 4 people have it, they can even close the institution to prevent further infection. Because through droplets, you're able to get it. No wonder we say it is a notifiable disease. Derek, is it okay?
Yes, sir. I have understood.
Great. Okay, quickly now, let's conclude. Questions. Which of the following organisms are likely to cause meningitis in neonates? A. Neisseria meningitis.
False.
Yes, false. B. Haemophilus influenzae type B.
False.
False.
False. Group B, streptococci.
True.
True.
True. Streptococcus pneumoniae.
False.
False.
Yeah, false. So only C. Which type of bacterial meningitis should an adjunctive steroid therapy be used? A. Community acquired meningitis regardless of etiology.
True.
True, sir.
Yeah, true. Meaning the rest are false.
Yes.
Which type of meningitis should those who came into contact with patients be given prophylaxis? A. Pneumococcal.
False.
False.
B. Streptococcal.
False.
False.
False. C. Meningococcal.
True.
True. D. None of the above.
False.
False.
That one is false.
Okay. The last one, now we go home. Or should we end? You do it in your own free time? Okay. Let's go through it quickly.
Let's go through it.
Okay. Anyone who can read from you? From that end?
A 4-week-old premature infant.
You should be sharp, Mike. Sharp. No, but then no.
Nicholas, mute your mic.
Can we mute our mics?
Oh.
Nicholas.
One day we're going to hear things we're not supposed to hear. Okay.
Yes.
Who is reading?
It is
Okay, go through.
a 4-week-old premature infant presents on the hospital neonatal unit with poor feeding, fever, and increasing drowsiness. Lumbar puncture reviews 1,200 white blood cells per microliter, which is 80% of which are polymorphs, and low glucose and elevated protein levels. No organisms are seen on a gram stain smear of the cerebrospinal fluid. The diagnosis is acute purulent meningitis. Questions. Number 1. What are the likely etiological agents?
Then 2, which other investigation other than CSF culture might help in establishing the etiological diagnosis? 3, what empirical antibiotic therapy should be commenced? Okay, so in your own free time, look at that and answer.